Thanks, Daniel. Good morning, everyone. So as Daniel said, I'm the Public and Patient Involvement and Engagement Manager here at Health Innovation Manchester, and I'm part of a small user-centred design team. It's a relatively new team that brings together business analysts and colleagues like myself who have undertaken public and community involvement and engagement previously, and basically we all work together to support the development of health and care services that meet the needs of end users, whether that be clinicians themselves, patients or the system. And before we hear more from project teams about the fantastic work that they've undertaken, I just wanted to give you a brief overview really of some of the activity undertaken by the user-centred design team as part of the programme. So, reducing health inequalities is basically a key driver of this programme. And the co-production and engagement workstream, which is a cross-cutting theme, like a golden thread that runs throughout the programme. The purpose of that workstream really is to help us really understand how we can increase access and uptake of advanced and community-based diagnostics amongst communities that are high risk of disease, but where we know there's low uptake of services and screening opportunities when they're offered. So to complement the work, the fantastic work and innovative approaches and strategies that were adopted by project teams, the user-centred design team undertook a whole programme of community engagement. And the purpose of this really was to raise awareness around the importance of early detection and screening, to promote the early detection of heart failure study, which was one of the projects on this programme. But we also wanted to really start exploring the barriers and enablers to early detection and screening, but from the point of view of different communities and patient groups across Greater Manchester. So how did we decide which communities to include? Well, secondary sources were important, but data and what that told us about the prevalence of disease across Greater Manchester played a key role, really. And our data analysts used a case finding tool that was utilised by the commercial company GraphNet, and that helped them to identify which communities were at greater risk, but also where they lived in Greater Manchester. But we didn't just rely on data alone. Some of the communities that we included in this work was informed by some of those known unknowns. So what we know, we don't know about communities, and that very much focused on, different communities' experiences of trying to access healthcare. But once we identified which communities to include, we worked really closely with the voluntary sector and community and faith leaders, because they've got relationships and trust with local people. So they were really well placed to start supporting us with recruitment, identifying accessible venues, arranging culturally appropriate food and catering, managing reimbursements, arranging, providing translation and interpretation support where needed. And as they know their communities best, they were also able to provide us with guidance around how was the best way to engage with different groups. And the voluntary sector provided the same type of support when we returned to sort of close that feedback loop and share our findings with the communities. But throughout the programme, it was really important that we reimbursed both voluntary sector organisations and public members for their time, in recognition that, they're not just giving up the time, but bringing knowledge and expertise. And that's, making a vital contribution to this programme. And this collaboration resulted in the co-creation of around 30 engagement activities and events involving more than 440 local people. And that was people from the most deprived backgrounds. It was also really ethnically diverse. And it also included people that have multiple risk factors for the diseases that were relevant to this programme. And together we co-produced around 32 outputs, and that's included posters, patient stories, short films and blogs. But what did we learn? Did we learn from this engagement? Well, to summarise, we learned that culture, language barriers, digital exclusion, practical and logistical challenges, mistrust, misinformation, worry and fear all plays a role. But also that health literacy and a lack of awareness around the importance of early detection and screening was an issue across the board. But we also learned that health literacy doesn't exist in isolation. It intersects with ethnicity, culture, language barriers, religion and spirituality, financial pressures such as food and fuel poverty, logistical challenges, digital access, and the challenges of trying to navigate a complex NHS, sexuality and gender identity, mistrust of health services and exposure to misinformation, homelessness, insecurity around housing and employment, mobility issues and the existence of other long-term conditions. So it's a complex picture. And all these factors affect people's ability to understand and act on invitations to attend NHS screening. And these factors may also help explain why some patient groups might delay screening, especially if they're asymptomatic, or wait until the symptoms become really severe. In terms of enablers, local people told us that early detection and screening would be far more accessible if information was culturally informed and easy to understand. If appointments were flexible enough to meet people's different accessibility needs and fit around their lives. And crucially, if services were brought closer to communities. They stressed the value of health awareness and interventions being led and delivered where possible with people who were known and trusted to communities. But if I had to narrow it down to just one takeaway from all this community engagement, it'd be the importance of taking the time to really understand your audience, really understand those communities that you're trying to include. Nasreen Akhtar, founder of Awakening Minds, a specialist Punjabi service based up in Rochdale, can articulate this much better than I can in this short film.
Okay, so we manage an organisation called Awakening Minds, which is a CIC, a non-profit. We're here to create better community-based support services to help those institutions to serve our communities better. That's why we're here. We specialise in Punjabi services because 99% of the battle is understanding the person, the faith, the culture, the community, the feelings, the experiences, the trauma, the history. We're here because our experiences and we want to make it better. So what can you do? Do what you're doing now. Ask us, listen to us, talk to us, treat us like we're human. We're not hard to reach, we're here. Come to us. We want to live longer, we want to stay happier, we want to be healthy, we want our children to thrive, and we want our families and communities and the nation to thrive. Come to us, sit with us.